Hello, my name is Tim Showalter. I'm a radiation oncologist at the University of Virginia and a member of the American Brachytherapy Society. I'm delighted to share with you my thoughts and summary about the long-term outcomes of monotherapy brachytherapy for low risk and favorable intermediate risk prostate cancer. So just for an overview, I'm going to touch briefly on how we make clinical decisions and select patients for prostate brachytherapy and the current thinking regarding that. I'll touch on some summary information regarding long-term outcomes that's been published for prostate brachytherapy. And I'd like to spend a little time highlighting recent advances from the vantage point of how they impact long-term outcomes for patients in a meaningful way and how we might interpret that as we approach patients in the clinic. So first of all, the potential advantages of brachytherapy are well described. Of course, it's a single episode of care in most instances, and in that perspective is convenient for patients. It's also a cost-effective option, especially as we consider moving our healthcare more into a value-based care model, and as we think about how our healthcare choices impact patients in the pocket in terms of financial toxicity. What I love about it is that it's a multidisciplinary practice. I enjoy working closely with urology colleagues, and brachytherapy, when done well, is done in concert with urologists and radiation oncologists making clinical decisions and performing the procedure together. There's a strong evidence base for excellent long-term outcomes, and it's been done for decades with a continuous advance towards increased technology that improves outcomes. There's widely available, established, and well-supported technology and product solutions to support tailored dosimetry and quality. Recent advances have further enhanced implant quality, especially leveraging learnings from MRI in the care of prostate cancer patients. And I'm really excited about how we'll see that evolve in terms of improving long-term outcomes, even beyond where they are now. So when selecting a patient for monotherapy, traditionally we've focused on low risk and favorable intermediate risk prostate cancer patients. So those Gleason 6-7 patients with favorable disease. In the era of MRI, increasingly, many practitioners are also offering monotherapy to selected patients with unfavorable intermediate risk when the MRI confirms that the tumor geometry can be appropriately treated with brachytherapy as monotherapy. Of course, the anatomy has to be suitable for an implant, so careful multidisciplinary evaluation of the prostate gland size, particularly with respect to risk for pubic arch interference during the procedure, is particularly important. And then lastly, adequate baseline urinary function is key. So traditionally we've used a symptom index score of either 15 or less or 18 or less as the cutoff. But this is a really great area to work in collaboration between radiation oncology and urology. And I found it very helpful to seek the guidance of my urology colleagues and to, when indicated, seek a urodynamic study to get greater insights into that particular patient. In terms of contraindications, so a relative contraindication is TURP. It really comes down to how large the TURP defect is and the risk for clumping or clustering of seeds after the implant. Large glands or large median lobes are also considered relative contraindications, as is poor baseline urinary function. The primary absolute contraindications are absence of a rectum, so it's the practical inability to insert a transrectal ultrasound probe, and unacceptable procedural risk. In terms of long-term outcomes, there are many reports. I've chosen from a submitted update to ASTRO and ABS recommendations for prostate brachytherapy, a selected list of series. And what's shown here is that over a range of study years, with a total patient representation on this table alone of about 15,000 patients, a summary of results that suggest about a 90% or higher rate of long-term freedom from biochemical failure reported across a range of treatment years. The follow-up for all these studies is relatively long. Recently, there's been increasing discussion about the use of undetectable PSA as a benchmark for success. And I would like to call your attention to the reference from Juanita Crook and colleagues, which demonstrates a very high rate of no evidence of disease among those patients with a PSA that is in the traditionally undetectable range of less than 0.2 nanograms per milliliter or equal to that. This is the plot of comparative outcomes generated by Grimm and colleagues. This is a well-known paper. I'm showing the 2012 update, and that group has continued to monitor outcomes over time. It's useful to demonstrate the clustering of results in a favorable location for prostate brachytherapy. I'm not showing this graph in order to compare across modalities, but I think it does emphasize that across a number of series, that the outcomes for prostate brachytherapy are excellent and tend to fall towards that 90% or higher range for freedom from biochemical progression, even with long-term follow-up. Now, this is for intermediate risk. The preceding slide focused on low-risk patients, and we see a similar trend in this approach where the brachytherapy containing approaches, either brachytherapy monotherapy, which is the subject of this, or in combination with seeds, where we're seeing outcomes that cluster around 90% PSA failure-free survival. Now, in terms of toxicity, the outcomes are favorable. I've shown here two prospective experiences that highlight a low rate of grade 3 GU toxicity. There is a note, we expect some degree of urinary effect in terms of obstruction and irritative urinary symptoms, but most of those are around the grade 2 range, and a quite low rate of GI toxicity over time. This is a hot off the press, so to speak, publication that I'd like to share with you that is in press currently in the Red Journal and is available for download on the webpage. And I discovered in preparing for this update. So what's shown here, the primary goal of this manuscript is to provide an overview for long-term quality of life effects for brachytherapy and external beam radiation therapy. And in this analysis, prostatectomy serves as a reference. But this data from patient-reported outcomes assessments demonstrates what we would clinically recognize is some long-term mild burden for urinary irritative and obstructive symptoms, as well as some impact on sexual bother. And so this confirms what we're aware of when taking care of patients, is that typically the urinary symptoms tend to be more obstructive and irritative after prostate brachytherapy. Recent advances. So the first instance of prostate brachytherapy that was described was really soon after radiation therapy really started and radium was discovered. So it harkens back to even 1911. But there have been continual advances in prostate brachytherapy technologies, particularly in recent years in the use of image-guided brachytherapy to plan radiation therapy, and the availability of computerized treatment planning to have conformal doses that are customized to an individual patient and to anatomic requirements. The most exciting thing that I've seen in my career is the overall impact of our clinical learnings from the use of magnetic resonance imaging in practice. And really, as a urologist knows, across the care continuum, increasingly when we're evaluating and supporting treatment decisions for patients, we're using MRI information. And that patient data leads to informed choices about the particular treatment approach. In the brachytherapy procedure, it also leads to informed trade-offs regarding tumor coverage, overall prostate gland coverage, and how to prioritize dose to the urinary structures. As we've gained more insights into prostate anatomy, including the location and importance of the urinary sphincter, the location of the neurovascular bundles with respect to an individual patient's tumor, and the presence or absence of aggressive tumor nodules. Increasingly, we're making choices related to our dosimetry in ways that better spare the urinary and sexual structures while preserving the tumor coverage that has delivered the high freedom from biochemical progression rates that I shared with you based on long-term follow-up. So the general gist that's been exciting to see unfold and that I think is still in evolution is how MRI supports personalized care. This is an example from a recent publication in Seminars in Radiation Oncology that highlights how tumor location near to the bladder neck can be identified and managed in the treatment planning process, as can the relationship between a tumor nodule and the urinary sphincter, for example, or the rectum. So it's a really exciting era to be a part of, and more and more we're making really personalized treatment decisions within the context of treatment planning for prostate brachytherapy. The most programmatic trend that has been gratifying to see and that I think has really delivered value for patients and improved the quality of brachytherapy is as we've used more and more MRI-based information to evaluate potential candidates for prostate seed implants and to refine our treatment planning within the context of an individual procedure, we've increasingly moved towards tailoring dose distributions to stop prioritizing exclusively what our whole gland coverage is, which was a fixture of brachytherapy as recently as 10 to 15 years ago, and increasingly embrace individualized treatment plans that may sacrifice some anterior gland coverage for the sake of reducing dose to the urethra and to the urinary sphincter. And I anticipate that that's going to pay great dividends in terms of further reducing urinary toxicity. So in summary, the available evidence, which represents long-term outcomes from a variety of series, demonstrates that brachytherapy monotherapy for low risk, for favorable intermediate risk, and for selected cases of unfavorable intermediate risk has very encouraging biochemical progression-free survival that's generally reported across series of 90% or higher. Long-term outcomes demonstrate already favorable GU, GI, and sexual outcomes. And I find it very encouraging and exciting to be a part of recent advances in image-guided brachytherapy, mostly related to the availability of information from MRI for individual patients that has led to reduced dose to urinary structures and more tailored doses to really embody image-guided personalized medicine. And I think in the future, we'll see continued excellent long-term outcomes in terms of freedom from biochemical progression while continuing to improve implant quality and enhancing urinary and sexual function for our patients. Thank you.